All right, let's talk male pelvic pain, pelvic floor muscle mojo, and pelvic floor physical therapy. This really needs to be part of your arsenal when it comes to treating male pelvic pain. As we know, it takes a village, and we really want you to go after this with a biopsychosocial approach. All right, before you understand chronic pelvic pain, you need to understand acute pain. These are two different processes, and chronic pelvic pain is simply not acute pain suspended in time. There are studies that reveal that when patients understand the biology of pain, they get better. Our treatments yield better results. In fact, a Mosley and Butler study looked at chronic low back pain patients, and when they added the educational piece of the biology of pain, those patients significantly did better than just receiving physical therapy alone. And in fact, if you do nothing else but educate on the biology of pain, a year from that time, your patient will have a 30% reduction in pain. Okay, so pain is communication. In acute pain, we know that the resulting sensation matches the stimulus. We have A delta and C fibers that get activated, and this communication goes up through the dorsal horn, in through the spinothalamic tract, up to the midbrain. The thalamus then relays information up to the somatosensory cortex, and then the return response comes down through the efferents. So in chronic pelvic pain patients, we get very unique, distinct processes that get set up into play. So something sets up this chronic noxious stimuli that comes in through the sacral cord to destabilize the neuronal circuits. Let's say it's chronic urinary tract infections, or let's say it's a patient that has a hypertonic pelvic floor from doing 500 kegels a day or sucking in their stomach, creating overflow to the pelvic floor. So this stimuli then creates changes at the level of the dorsal horn, and we get these chemical mediators that start to show up. Things like substance P arrive on the scene. They start to activate silent afferents that normally don't carry signals and pain perception up through the cord. So when we talk about silent afferents, these C fibers, it's interesting to note that the majority of those silent afferents are located in the viscera. And guess what organ has the most silent afferents of all? It's the bladder. So one of the reasons we see such a high volume of bladder pain, whether true interstitial cystitis or hypertonic pelvic floor driven pain patients. So next, we see neurogenically mediated inflammation that starts to occur. So we don't just have inflammation peripherally at the site of the original insult, but we can see it within the spinal cord. And because of all these metabolic changes that are occurring, our patients start to experience a centralization of pain. So the spinal cord becomes an essential organ to treat besides the bladder, besides the pelvic floor. And on top of that, crosstalk can start to happen where we get expansion into levels above and below the initial affected level in the cord. And this is how we see pain that starts to metastasize. So next, let's consider what happens at the level of the brain. So we know that many parts of the brain get involved during the pelvic pain experience. And in fact, there can be a specific firing pattern of activity that creates the perception of pain that becomes a neurosignature for that pain stimulus. And this has been referred to in the literature as the neurotag for pain. So patients that start to fire on neurotags can do so without anything physically changing. In fact, there was another interesting study that was done where they took patients who had hypertonic pelvic floors and they did needle EMG into the muscular element of the pelvic floor, and then they went adjacent externally to other muscles. And they proceeded to show patients a scary scene of a movie or asked them to do difficult arithmetic and measured then the electrical output of the pelvic floor. When the patient perceived threat, so whether that was like, I don't know what's going to happen with this next scene of the movie, or I don't want to look dumb, I better perform on this time test, the electrical output of the pelvic floor muscular element shot up. But what was wild was that the adjacent external musculature actually stayed quiet. So this comes back to neurotags being fired, pain being, again, a communication system and a result when perceived threat is present. So with neurotags, we know that a strong emotion can be a reason for a neurotag to fire. We know that fear can set off a neurotag from firing. And so when we start to treat this patient population, now my goal is for you to understand that we need to treat peripherally, we need to treat within the cord, and we need to treat the brain. So now that you've had a crash course in chronic pelvic pain, let's bring this back to a few practical things that you can integrate and look for in the clinic. I want to really hone in for the rest of this time talking about what is being missed again and again with routine questioning and with pelvic examinations. So it's a pelvic floor muscular element that's getting missed again and again. Over the last 25 years of practice, this is something that I routinely see that is missing on the radar and missing in the physical exam of most pelvic pain patients. So the pelvic floor muscles are skeletal muscles that exist both externally. We have superficial pelvic floor, and internally we have deep pelvic floor. And these muscles can become dysfunctional just like any other skeletal muscle in your body, manifesting what's known as trigger point presence, and they can become hypertonic and have too much electrical activity at rest. Okay, so in this presentation, it's very common that these muscles then will have trigger points that will refer pain to other regions of the body. And that's why I call these muscles the great deceiver. I would love for you to be familiar with the referral patterns of the pelvic floor. And these include to the lower abdomen, to the hips, to the low back, to the genitalia. The muscles can reproduce, quote, organ pain, and patients will swear that they have a urinary tract infection. They will swear that there's a bacterial infection going on. They will swear that their prostate, right, is inflamed and irritated, despite everything coming back negative in terms of cultures and specialized testing. So when the pelvic floor muscles become really angry, we start to see dysfunction that shows up. And the dysfunction of the pelvic floor relates to the function of the pelvic floor. And when we look at what the pelvic floor muscles actually do, we categorize it in 4 different basic functions. There's a sexual functioning role. And so patients who have hypertonic pelvic floors can present with painful sex or sexual dysfunction. There's a stability functioning role of the pelvic floor. We know these muscles fire with every step we take, with the deep abdominal wall muscles, with the low back muscles, and they create stability of the sacroiliac joints, the pelvic girdle, and even the low back. We know there's a sphincteric role and that these muscles need to fire appropriately to help close the urethral sphincters and as well as the external anal sphincter. And if the muscles become hypertonic, then they actually can create urinary retention, outlet constipation, and results in a muscle not being able to move through its full range of motion. So therefore, it cannot, the hypertonic pelvic floor actually can contribute to urinary or fecal incontinence as well, because the muscle becomes, quote, weak, not being able to move through its range of motion. And then lastly, there's a supportive function. These muscles help hold up all the pelvic organs. And so the dysfunction manifestation typically is pelvic organ prolapse. So what makes the pelvic floor muscles unique and probably the coolest set of muscles in the body? Well, number one, we already talked about them being the great deceiver. These muscles refer pain to other areas of the body, causing you as the practitioner to be a great detective, keeping these muscles on your radar, recognizing the referral patterns and recognizing that likely there is a muscular element to your pelvic pain patient's presentation. Number two, these muscles sit at the crossroads of the body. Part of their job is to attenuate forces coming up from the foot to the pelvis. We have ground reaction forces that are carried through the lower kinetic chain, and then they get balanced in through the pelvic girdle. These muscles also help then deal with the forces coming from the upper body and trunk down into the pelvis and intra-abdominal pressure that is being exerted here. We know that these muscles respond also to pressure changes within the abdomen. When the diaphragm descends, the pelvic floor descends. So if our patients are using faulty breathing patterns and not utilizing the diaphragm, this can also contribute to a hypertonic pelvic floor. Lastly, these muscles are governed by the autonomic nervous system. So the more time our patients spend in fight or flight, the more dysregulated they are, the more hypertonic and turned on these muscles will be. So what are the common side effects of a hypertonic pelvic floor? We've already mentioned a lot of them. You want to look for these patterns that exist. So a patient may come in with not just urinary symptoms, whether it's UTI-like symptomology or urgency frequency, but they also then may present with low back pain and hip pain and orthopedic presentation of their pain or tailbone pain. They may have a bowel presentation with outlet constipation. They may have sexual dysfunctioning component, right? Whether pain with sex or orgasm or erectile dysfunction. So we will see, again, this cluster of symptomology when a hypertonic pelvic floor is present. So why does the pelvic floor become hypertonic in the first place? Great question. And you can leave that up to us as the pelvic floor physical therapist to really get to the root cause and figure this out. Because if we don't, the hypertonic pelvic floor will return. But to quickly educate you, we're always looking at a biomechanical underlying dysfunction. Is it related to chronic faulty posture and how they're standing? Do they truly have spinal changes like a scoliosis? Is there an SI joint dysfunction, such as a hypermobile SI joint? And we know that the pelvic floor, because part of its job is to create stability through that region, will compensate. Was there an injury to the pelvic floor sometime in their past? It may not be recently. There could have been an old fall onto the tailbone. All of the pelvic floor muscles attached to the tailbone. If that coccyx is sitting, whether hyperflexed, side bent, or rotated, you will have a change on how those muscles attach to the base of the spine. Was there a pelvic surgery that happened or a spinal surgery that happened before the onset of pain? We had a patient actually with testicular pain who came to us, and he was ready to have his testicle removed. He came in and just as a last-ditch effort, was like, my wife forced me to come in here. So through his history, I quickly was able to correlate that his onset of testicular pain happened within 3 weeks after having spinal surgery. His doctors told him it was coincidence. We were able to fully resolve all his testicular pain, save the testicle from being removed, and get him to be pain-free. Okay, another thing to consider is, was there inflammatory pain disorder present, such as a true interstitial cystitis in our female patients, endometriosis, or male and female irritable bowel syndrome that created an inflammatory response, and therefore the pelvic floor then became activated in a hypertonic way. And lastly, then consider also unhealthy pelvic floor behaviors such as straining to defecate, improper breathing patterns, just chronic sitting, and then just holding patterns from stress and anxiety. So when your patients present and complain of any of these hypertonic pelvic floor signs and symptoms, please perform a pelvic muscular exam. I would love this to be routine, honestly, whether they complain of pain or not. I think if we could catch these patients early, send them over for a few visits of PT, we would remarkably change outcomes and prevent some of the long-standing cases that I tend to get in my practice where I'm chasing it after it's been present for years. So to do that, you're going to look at both a superficial and a deep layer of muscles. It's beyond the scope of this presentation. If anyone is interested, I would be happy to put together a separate presentation training physicians on how to routinely do this. You need to get familiar with the anatomy. You need to look at the 3 superficial pelvic floor muscles and be able to palpate what healthy muscle feels like versus unhealthy. You're looking for trigger point presence, bands, nodules, and reproduction of any symptomology as you're palpating, both externally and internally. Okay, so the deep pelvic floor goes from the pubis and then does wrap around the external anal sphincter and attaches to the base of the spine. So here's just a quick glimpse into a patient that I treated with pudendal neuralgia who presented with testicular pain, sexual pain, tailbone pain, penile burning, and had the inability to sit. I just wanted to highlight some of the themes we've talked about today. He had spinal changes. He had a scoliosis, postural changes. You can see from the side, a major scar going down through his abdomen, influencing fascia that pulled right down into his pelvic floor. He had a true leg length difference. He had coccyx dysfunction that we had to treat, and therefore a hypertonic pelvic floor was at the root of so much of his pain and symptomology. I'm giving you a quick peek into what pelvic floor PT treatment involves. It absolutely does involve an internal treatment component with manual therapy to release and lengthen the pelvic floor, to take tension off the pudendal nerve as it runs its course through the pelvis. But there's a lot of external work that we do as well. There's a huge educational piece. We have already talked about at the beginning of this presentation, educating on the biology of pain. We educate on bowel and bladder techniques and voiding techniques. We do postural, external education. We release what happens essentially head to toe. We are body detectives on the case, and then we empower patients to be able to treat themselves. So in summary, do not forget the pelvic muscular element of pelvic pain. It is there. It is being missed. Find a pelvic floor physical therapist or an occupational therapist close to you. Develop a collaborative relationship. These patients need a multidisciplinary and team approach, and we can absolutely make a dent and create better quality of life for these patients. Thank you.